Hi, today my topic of discussion will be traumatic injuries to the anterior teeth. In this, I will be discussing about introduction, classification, diagnosis, clinical examination, radiographic examination. Now, if you see the anatomy in a child and an adult, anatomy in a child, alveolar bone is a soft one, so it takes the maximum forces which is transmitted to it. And so, in a permanent dentition, the forces are transmitted back to the teeth because of a hard bony architecture. Now, if you see the etiology, there are various etiological factors of these. The first one is the sporting activities like contact sports, biking, bicycle or horse riding. And second is the child abuse and neglect. And third one is the accidents, falls, habits and handicapped child. Last one is the poor motor coordination. Now, if you see the pattern of a traumatic injuries from 18 months to 2 years, it is like a avulsion rather than the fracture. And it will be more like a ulnar injury. In 2 to 5 years, it is because of an injury starting to run or walk. So it will be like a forward injuries to the anterior teeth, and it will be similar pattern to the previous one. In 5 to 10 years, it will be like a soft tissue injuries and crown fractures. And after 10 years, it is mostly contact sports and RTA. And the predisposing factors for a traumatic injuries is the convex profile, which makes anterior teeth bone caries injury, and the inadequate lip coverage. Lip acts as a cushion to the teeth. Whatever forces or whatever is transmitted first to the lip, then to the teeth, and increased overjet. In a handicapped child, there is a more chance of injury because of poor motor coordination or epileptic attacks or abnormal muscle tone. The various minor factors which determine the impact of injuries, the energy of the impact. Higher velocity, low mass will have a different impact compared to the high mass and low velocity. And low velocity causes more blow than the damage to the supporting tissue. And high velocity causes fracture. And the resiliency, the difference between the resilience of impact, like it's like a rubber or a hardwood. Rubber will have a more impact of a luxation, whereas hardwood like thing is cause a fracture of that alveolus or a teeth. And the shape, the sharp objects will have a fracture, whereas the blunt objects will cause a luxation injury. And the angle of the direction will cause the intrusion or extrusion injuries, or palatal luxation or buccal luxation injuries. If you see the epidemiology of injury, it's like a primary dentition, there is a high occurrence compared to the permanent dentition. And boys are more prone to injury than the females. And the peak incidence we can see in 2 to 4 years and 8 to 10 years. And the location of injury, maxillary and central incisions are most commonly involved than the mandibular incision. The type of injury in primary dentition, it's a luxation injury. Permanent, it's a complicated or uncomplicated fractures. Now you can see the classifications of traumatic dental injuries. Most commonly we use Anderson's classification, Ellis classification, and Garza-Cordes classification. Ellis classification is a simple one, coming from an outer part of the teeth. First one is a tooth involving little or no dentin and an enamel fracture. Class 2 is a extensive fractures of tooth involving considerable dentin without involving the pulp. 3 is a extensive fracture involving the pulp. 4 is a non-vital teeth. 5 is a avulsion injury. 6 is a fracture of the tooth root with loss of bone structure. 7 is a displacement of teeth with fracture or without fracture of the root. 8 is a crown and mass. 9 is a traumatic injuries to the primary teeth. There is a modification done by a McDonald. In class 1, it is a simple fracture of the crown with little or no dentin. 2 is a The fracture of a dentin without involvement of the pulp. 3 is the extensive fracture of the crown with exposure of the pulp. 4 is the entire crown loss. Raven's classification is a class 1 is enamel fracture, 2 is enamel and dentin fracture, 3 is enamel dentin with pulp exposure, 4 is a root fracture, 5 is a combination, 6 is the exarticulation. Garcia's classification is for a primary teeth. Class 1 enamel fracture, class 2 enamel dentin fracture, class 3 enamel dentin fracture with pulpal exposure, class 4 is enamel dentin fracture, cemental fracture, 5 is a root fracture, 6 is a concussion, 7 is a luxation, 8 is the extrusion, 9 is the avulsion. Now Anderson classification is a different classification which divides most of the tissues, like hard tissues, supporting tissues and soft tissues. First one is the injury to the hard tissues and pulp. The injuries to the hard tissue and the pulp, we have enamel infection, enamel fracture, enamel dentin fracture, complicated crown fracture which exposes the pulp, uncomplicated crown root and fracture without exposing the pulp, complicated crown fracture with exposing the pulp, root fractures in periodontal tissues. We have a concussion, subluxation, extrusive luxation, lateral luxation, inclusive luxation, avulsion. And injuries to the supporting tissues, which include maxillary or mandibular fractures, annular process, or socket. In gingiva, we have a laceration, contusion, abrasion. And there is one more classification, which is the WHO classification, which gives a code like 873 for a dental tissue. We have a 60 for enamel, 61 for dentin fractures without pulp. Like that, we have each and everything number for tissues. In examination of a patient with dental trauma, we need to diagnose the injury as well as a causative injury, as well as the etiological factors and the pattern of injury. And we need to check the mental conditions, all the systemic conditions, allergies and hospital vital signs, respiratory systems, whether the patient is in a shock, whether it is associated with hypotension or any airway obstruction. There is a pattern for diagnosis. How did the injury occur? When did the injury occur? Where did the injury occur? Was the patient conscious at that time and is he associated with any nausea, vomiting, and he has any previous injury, or is it recurrent, or is the first time? Is there any disturbance in the bite? And then comes the testing of the teeth, then pertinent medical history. In clinical examination in soft tissues, we need to check for lacerations, contusions, and tissue abrasion and presence of foreign bodies. Laceration is usually done with a sharp object. Contusion is done with a blunt object where we can see a submucosal hemorrhage. Abrasion is the surface is rubbed, leaving a raw bleeding surface. So these are the tissue surfaces: abrasion, contusion, laceration. The teeth fracture. Teeth we need to check for the fracture, mobility, displacement, injury to the perineal tissues and pulp. In hard tissues, we need to check for crown fractures, exposure, and status of the pulpal circulation by pulp testing, displacement of the teeth by radiograph and clinical examination. And the mobility test we need to check with whether the teeth is mobile vertically and horizontally as well. And we need to grade the mobility of a tooth based on the extent. Like 0, there is no change. Horizontal loosening 1 mm, it's grade 1. Horizontal greater than 1 mm. Grade 2, axial 3. So this is how we check. And electromagnetic sensibility testing, we go with the electrical testing. First, we need to check with the cold testing, and in the first few weeks of injury, we need not rely on the pulp testing because the tooth is under trauma, so the response is not accurate. But for a standardization, we need to take pulp testing, and the radiographic test we need to check whether we have any fractures, which is associated dental fractures or root fractures, in confirmation on the clinical examination. If there is a root fracture, we need to take two exposures. One is a normal exposure, and another is a reduced exposure from 25 to 50%. And we need to check the foreign bodies. So this is about the examination and diagnosis of a